Hi there. In my previous video, I briefly explained the anatomy of the spine and the makeup of the disc. I also showed some MRI images of the lumbar spine, which was normal, and MRI scan of a few patients with a disc prolapse in the lumbar spine. In this video, I would like to talk about the symptoms of sciatica, which is as a result of a disc prolapse, a herniated disc, a slipped disc, and disc herniation in the lumbar spine. I usually use these four terms: disc prolapse, disc herniation, herniated disc, and slipped disc interchangeably. They all mean the same thing, and there is a subtle difference between them and a disc protrusion. A disc protrusion does not cause massive, I would say, impingement on a nerve root. It is a bit wider, and the front back diameter is a bit less than a herniated disc. So here in this video I'm talking about a disc prolapse. I'm not talking about a disc protrusion. Before I start talking about the symptoms of sciatica, I would like to answer a few common questions. The first one is, which discs tend to prolapse in the lumbar spine? If you look at the model of a spine, you will see here these are the lumbar vertebrae, and here the sacrum, and you will see here this is a disc between L5 and sacrum, and the next disc, and so on. About 90% of herniated discs in the lumbar spine are located between L4 and sacrum. I mean the last two discs, the disc between L4, L5 vertebra, and also the disc between L5 vertebra and sacrum. The remaining disc in the lumbar spine from L1 vertebra to L4, they might contribute to about 10% of disc prolapses. So the majority of them are at L4-5 and L5-S1. I would say almost 90%, and some say up to 95%. And if you break down these two discs, you will see that the majority of them are at L5-S1. I mean the last disc, and the L4-5 has got less percentage of the disc herniations here at these two levels. A disc prolapse at the level L5-S1, I mean the last disc, impinges the first sacral nerve in the majority of cases, which is called S1 nerve root. And a disc prolapse at the level L4-5 impinges the nerve root L5. Usually a disc prolapse impinges the nerve root which exits the spinal canal below the level of the disc. So the disc prolapse at the level L4-5 impinges the L5 nerve root in the majority of cases, and the disc prolapse at the level L5-S1 impinges the S1 nerve root in the majority of cases. That was the first common question. The next common question is why a disc herniates. The disc, like other structures or organs in the body, undergoes aging changes or degenerative changes. And one reason for that is the blood flow of the disc, which is compromised sometime in our teens. So due to, I would say, shortage of blood flow, and later on probably lack of blood flow, the disc degenerates faster than the other structures in the body. As a result of that, the outer ring of the disc, which is called annulus, gets some cracks, some fissures, or even ruptures, and the jelly core, which is in the middle, can escape out, and it can impinge the nerve root which is around. The jelly core is an amazing structure in the body. It has got proteins which can trap water 500 times their weight. And the jelly core is the part which enables the spine to bend forward, or backwards or turned to the side. So without the jelly core and without the disc, I would say these kind of movements were not possible in our spine. Most patients with sciatica as a result of a herniated disc are in their 30s and 40s, not in their teens or 60s or 70s. Of course, we get some patients who are in their teens with a disc prolapse, or in their 60s and 70s with a disc prolapse, but the majority of them are in their 30s and 40s, probably up to mid-50s, but 30s and 40s are the majority of the patients with a disc prolapse. Now I would like to talk about the symptoms of sciatica. The first symptom is pain, and pain is described as a sharp, excruciating pain or as a dull ache or discomfort. It is usually in the buttock, back of the leg, and also outer side of the leg. The pain pattern changes from one patient to the other, and it is not the same in every patient with sciatica. It is usually in the leg, not in the back. So if you ask this patient to rate back and leg pain, they would tell you that 70-80% of the pain is in buttock and leg, probably 20 to 30% in the back. They don't experience much of back pain. Whereas if you speak to someone with chronic back pain, someone who has got back pain for many years, they would tell you that the majority of pain is across lower back and not much of leg pain. So this is something which distinguishes sciatic or patients with sciatica from patients with chronic lower back pain. One other important thing here is that the intensity of pain varies from one patient to the other. Whereas we have patients with severe excruciating pain who would tell you the pain is probably 8 or 9 or even 10 out of 10. We have patients who would say their sciatic pain is probably 1 or 2 or 3 out of 10. Some people are unable to mobilize, they're unable to stand or walk because of the pain intensity. They cannot weight bear on the affected leg, so they usually walk with a limp. Sometimes they may use a walking stick, or they may use a kind of elbow crutch in order to be able to maintain their balance. So pain can start all of a sudden. The patient may say, I woke up or I lifted something and all of a sudden the pain was there, and from the beginning it was probably 8 or 9 out of or 10 out of 10. And sometimes your patients, they say, no, it was as a kind of dull ache at the beginning, but over time it has got really bad and it is now probably 7, 8 out of 10. We have patients who may not take any painkiller. They would say the pain is manageable, they don't need any painkillers. Probably they need to reduce some of their activities in order to manage the pain, but they can still work, they can still function. And we have patients who cannot do anything. They are so disabled by the pain, incapacitated by the pain. They cannot sit, they cannot stand, they cannot walk. They have difficulty finding a comfortable position, and they take various painkillers and even morphine and probably still feel pain. Sometimes the pain can affect the sleep at night. Some people have difficulty at night to fall asleep because of the pain, or they have difficulty to find a comfortable position at night, so they cannot sleep well, and as a result of that they are in a bad mood because they couldn't sleep at night, and that can also add to the pre-existing problem, which is here sciatica. I think this is all I can say about the pain. The next symptom is numbness. Patients with sciatica may experience numbness. The numbness can be in the buttock area, in the back of the thigh or outer side of the thigh. It can go down to the calf, it can go down to the foot, and toes can be affected. It is not there all the time. but some patients experience numbness, and usually it is below the knee, it is in the calf and in the foot. The next symptom is pins and needles, and pins and needles, similar to numbness, can be there, or some people may not experience pins and needles at all. So if pins and needles are there, they are usually again in the calf area or in the foot, sometimes in the toes, and at times also in the thigh area, but usually we see these symptoms, pins and needles, below the knee. The next symptom is weakness, and it can be in the foot or in the leg. Patients who have weakness would say if they walk, the leg gives way, or the foot is weak and they stumble over that. As a result of that, they try to use a walking stick or an elbow crutch in order to maintain their balance. It is not that every patient with sciatica experiences weakness, but some of them have weakness. Some of them have all the symptoms I described, such as pain, numbness, pins and needles, and weakness. And some of them have just one or two, like pain and numbness, or pain and weakness, or pain, pins and needles, and weakness. So every patient varies from the other. Usually the bladder and bowel function is, in patients with sciatica, intact. What I mean is they can control the bladder and bowel function. Sometimes some patients with sciatica may become constipated, and it can be due to painkillers they take, or lack of movement, or at times because of pain on sitting. Some patients say if they sit on a toilet, they experience significant pain, and the pain gets worse. So as a result of that, they try to avoid going to the loo, and then they become constipated. But overall, the function is still intact. The bowel function is intact, and the bladder function is intact too. They may have a kind of urinary frequency. It means they go to the loo quite often and empty the bladder because of pain, but they still have the control over the bladder. There is a serious medical condition called Cauda Equina Syndrome, and it is an urgent medical condition, and it doesn't happen very often. We say about 2% of patients who go for spinal surgery, which is called discectomy or decompression as a result of a herniated disc, have Cauda Equina Syndrome. So it is quite rare. We know that about 2% of patients who undergo spinal decompression, spinal discectomy, have Cauda Equina Syndrome. I'm going to talk about the treatment options of sciatica later, but I would like to make one statement in advance. We say that about 90% of patients with sciatica as a result of a herniated disc don't need any operation. They can manage their symptoms with non-surgical treatment strategies. So 2% of these 10% may have Cauda Equina Syndrome. It is so rare. It is not very common. Patients with a Cauda Equina Syndrome may have all the symptoms of sciatica, plus they have numbness in the upper part of their thighs, in the genital area, around the back passage, which is called saddle anesthesia. They also have bladder incontinence. They cannot control the bladder function. They wet themselves. Or at times they say they cannot empty the bladder whatsoever, probably for 12 hours, 24 hours. They may also have bowel incontinence, so they soil themselves and they don't have the control over the bowel movement. Most of the time we see the first one, which is the bladder incontinence in patients with Cauda Equina Syndrome, and at times we see bladder incontinence and bowel incontinence together. It is an urgent medical condition. Patient needs to go to the local A&E department as soon as possible. if they talk to their GP or to the doctor they see first, they will advise them to go to the A&E department urgently. And once they are there, the doctor will organize an MRI scan of the lumbar spine. They may also get ultrasound of the bladder after they tried to empty the bladder. And if they identify a Cauda Equina Syndrome, and this is a condition which requires urgent surgical intervention. As I mentioned earlier, it is very rare. Most of the time, patients who come to A&E department with Cauda Equina Syndrome, they don't have a genuine Cauda Equina Syndrome. They have got probably a herniated disc causing problem in the leg, numbness and all these things, but the bladder and bowel function is still intact. And what causes a Cauda Equina Syndrome? It is usually as a result of a massive disc prolapse in the lumbar spine at the level L4-5 or at the level L5-S1, but it is usually massive. It is a huge disc prolapse which impinges the nerves on both sides, right and left. And one would not experience Cauda Equina Syndrome if the disc prolapse was on one side. And it has to be on both sides in order to cause the symptoms. I think I've covered the most important symptoms of sciatica, and in the next video I would like to talk about the treatment options of sciatica. I'll see you shortly in the next video.